This video is about risk factors of miscarriage as well as recurrent pregnancy loss. This is the outline for the presentation. Introduction, risk factors, risk reduction, etiology, approach to recurrent pregnancy loss. Miscarriage is the most common adverse pregnancy outcome, accounting for 5 to 15% of all pregnancies.
It is also referred to as spontaneous abortion, generally defined as non-viable intrauterine pregnancy up to 24 weeks.
Early pregnancy loss, which occurs in the first trimester, is the most common type. Unfortunately, prevention is the only way we can intervene. Risk factors can be divided into modifiable and non-modifiable risk factors. Under non-modifiable risk factors, it includes increasing maternal age with more than 35 years being most significant due to its strong association with fetal chromosomal abnormalities. Other non-modifiable risk factors include prior pregnancy loss, maternal medical conditions such as diabetes mellitus, obesity, and thyroid disease. Some examples of modifiable risk factors include medication use such as NSAIDs and teratogenic drugs, substance use including smoking, caffeine, alcohol consumption will also increase risk of pregnancy loss in dose-related fashion. This means that an increasing amount of substance used will lead to increasing risk of pregnancy loss. Multiple agents have been studied to reduce the risk of miscarriage. Only low-dose aspirin has been shown to be helpful in some individuals, though it should not be for routine use. Prenatal vitamins in preconception, periconception, and early pregnancy timeframes do not prevent early pregnancy loss. However, folic acid reduces risk of miscarriage compared to having no supplementation and reduces risk for stillbirth. Common etiologies of pregnancy loss at any gestational age include chromosomal abnormalities, maternal anatomic abnormalities, and trauma. For individuals with second trimester loss, additional etiologies must be considered. We will go into more detail for the more common causes of pregnancy loss in subsequent slides. Chromosomal abnormalities are present in up to 70% of pregnancy losses before 20 weeks. Prevalence varies by gestational age. This includes aneuploidy, whereby there is missing or extra chromosomes due to sporadic errors during chromosomal division and duplication. Many of the abnormal chromosomes are incompatible with life and thus result in miscarriage. The most common chromosomal abnormality found in first trimester loss is trisomy 16, whereby there are 3 copies of chromosome 16 instead of 2 in normal individuals. Maternal anatomic anomalies are another common etiology of pregnancy loss. This includes polyps, adhesions, or septa. However, not all anatomic anomalies will result in a miscarriage, but rather the size and position of the anomalies are important factors affecting the pregnancy. Uterine leiomyomas or fibroids have no reported association to pregnancy loss, but the impact of fibroids on pregnancy loss likely varies due to other clinical aspects as well, such as distortion of uterine cavity and/or blood supply. Significant trauma can cause pregnancy loss. While the developing embryo is relatively protected within the uterus in early pregnancy, trauma that results in direct impact to the uterus can cause pregnancy loss. This can be due to violent trauma such as penetrating injuries or iatrogenic trauma such as chorionic villus sampling or amniocentesis. Individuals with second trimester pregnancy loss often present with varied conditions and underlying pathologies such as preterm premature rupture of membranes. Oftentimes, second trimester pregnancy loss has more than one cause, and often no specific etiology is identified. However, some known etiologies of second trimester pregnancy loss include an infection, uterine malformation, cervical insufficiency, thrombophilus, fetal malformation, or syndromes such as anencephaly, renal agenesis, hydrops. Other obstetric conditions such as placenta abruption and preterm premature rupture of membranes are important etiologies as well, which will not be covered in this presentation. In the case of recurrent pregnancy loss, the risk factors and etiology varies and should be considered for relevant workup according to clinical presentation. Recurrent pregnancy loss is defined as 2 or more pregnancy losses diagnosed by either serum or urine human chorionic gonadotropin. This diagnosis includes biochemical pregnancies and treated pregnancies of unknown location, but does not include confirmed ectopic or molar pregnancies. Although recurrent pregnancy loss is an important problem, the cause of RPL can be determined only in 50% of patients. General etiological categories include anatomic, immunologic, genetic, endocrine, infectious, thrombophilic, and environmental factors. Under anatomic, septate uterus is the most common uterine abnormality associated with RPL. Others include adenomyosis, intrauterine adhesions, and defective endometrial receptivity. Other conditions more pertinent in RPL compared to a single pregnancy loss include antiphospholipid syndrome, polycystic ovarian syndrome, thyroid diseases, hyperprolactinemia. A stepwise approach is taken to evaluate individuals with RPL. Anatomical causes of RPL are evaluated with a uterine assessment, typically using hysterosalpingography or sonohysterography. Hysteroscopy, laparoscopy, or MRI can also be performed as needed, though are more commonly used as second-line tests when additional information is required for diagnosis. A minimum immunology workup for women with RPL includes the anti-cardiolipin antibody IgG and IgM for antiphospholipid syndrome, as well as lupus anticoagulant for SLE. Thyroid function should be assessed in women with clinical manifestations or a personal history of thyroid disease. As there is evidence of increased risk of miscarriage in women with subclinical hyperthyroidism and euthyroid women with thyroid peroxidase antibodies, screening of thyroid function in asymptomatic women can be considered. Karyotype of both parents is done to detect genetic abnormalities that could have been inherited by the fetus and thus resulted in the pregnancy loss. However, as there is low likelihood of abnormal karyotype in couples with RPL, karyotype is often the last test done. Apart from those mentioned above, other tests are less useful and performed depending on the presentation of each patient. In summary, we covered briefly the risk factors and etiologies of pregnancy loss. We also went through the approach to recurrent pregnancy loss. Quiz time. Question 1. Which of the following is a modifiable risk of pregnancy loss? Question 2. Which of the following is the most common cause of first trimester miscarriage? Question 3. Which of the following is not part of the initial workup for recurrent pregnancy loss? These are the references used for further reading. Thank you.